I'd like to welcome everyone to today's webinar, Family Meetings, Improving Patient-Family Clinician Communication. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national nonprofit leading the movement to bring compassion to every patient-caregiver interaction. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 1 hour. The first 40 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the program. Please note that attendees are participating in listen-only mode, but can interact with the speakers and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we'll address as many of them as we can at the end of the formal program. As you exit the webinar, you'll receive an electronic survey that we ask you to take a minute to complete so that we may capture your assessment of today's program. Your feedback is really important to us. And now it's my pleasure to introduce my colleague and our host for today's session, Dr. Beth Lown. Beth is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Beth?
Thank you, Lynn, and good afternoon, everyone. Family meetings are a routine part of our care for seriously ill patients and their families. An effective conduct of these meetings has been associated with improved patient care and improved family outcomes. This webinar will review some of the evidence for the conduct of effective family meetings and provide tips and suggestions for the whole interdisciplinary team to improve the conduct of this really important aspect of healthcare. And it is my pleasure now to introduce today's speaker, Dr. J. Randall Curtis, who is the A. Bruce Montgomery American Lung Association Endowed Chair in Pulmonary and Critical Care Medicine at the University of Washington. He's Professor of Medicine, where he's also the section head for Pulmonary and Critical Care Medicine at Harborview Medical Center. And he's the director of the new University of Washington Palliative Care Center of Excellence. Dr. Curtis's research focuses on improving palliative and end-of-life care for patients with critical illness and chronic and life-limiting illness, as well as their families. He's had an active research program with over 15 years of continuous funding from National Institutes of Health. He's offered numerous peer-reviewed research articles, editorials, and chapters, and has been the recipient of as many awards for both his research and teaching. We're just so pleased to have him with us today. Welcome, Dr. Curtis.
Thank you, Beth. I'm really happy to be here today.
So we're all very excited about today's program, and we're just going to let you get started.
Great. Thanks very much. So I'm going to focus on family meetings, particularly in the ICU, although I think family meetings can occur in other hospital settings and also outside of the hospital. First of all, I have no financial conflicts of interest to disclose, but I do like to acknowledge my funding sources, which includes our healthcare system, UW-Medicine, and as well as the Cambia Health Foundation, and federal funding sources including the National Institute of Nursing Research, the National Heart, Lung, and Blood Institute, and PCORI, the Patient-Centered Outcomes Research Institute. What I thought I would do over our 40 minutes together is cover these topics. I'm going to talk a little bit about the importance of family meetings, spend a little bit of time talking about shared decision-making and how I think our thinking about how we should do shared decision-making has changed over the last 5 years or so. I'm going to talk about some tips for running and teaching good family meetings, talk a little bit about using family meetings as a quality measure, and then finally finish by talking about the role of interdisciplinary communication in conducting good quality family meetings. I think anyone who works in the ICU setting knows that end-of-life care is something that we do a lot of. About 1 in 5 deaths in the U.S. occur in the ICU or shortly after a stay in the ICU. And this slide shows data from Derek Angus and his colleagues looking at the proportion of deaths that occur in the hospital, the total height of the bar. The dark bar is the proportion of deaths that occur in the ICU. And what you can see is that in the very young, almost 50% of deaths occur in or shortly after a stay in the ICU. That goes down to about 20% in the teen years and really stays at 20%, doesn't even begin to go down until over age 80. And so with our aging population, we're seeing increasing numbers of deaths occurring in the ICU around the U.S. This slide shows the changes between 2000 and 2009 for Medicare beneficiaries. So this is patients over the age of 65. And if you look at the blue bar, you see over that time period we've had a pretty dramatic increase in the proportion of patients who are in hospice at the time of death, from a little over 20% to over 40%. But shown in the red bar, a portion of that increase is for patients who are only in hospice the last 3 days of life. So this is really not enough time for hospice to be able to do as much good for patients and their families as they can. These data also show in the purple line, the top line, that the proportion of deaths that occur with an acute care stay in the last 90 days is increasing. And the green line shows that the proportion of deaths that involve an ICU stay in the last 30 days of life is also increasing. So while we're seeing more hospice use, we're also seeing increased intensity of care at the end of life and an increase in the number of transitions between care settings that patients and their families must go through, which has been shown to increase distress for both patients and their families. We also know there's tremendous variability in how we approach these issues from ICU to ICU. These are data that were published in CHEST in 2014 showing that each black dot is an ICU. And this shows the proportion of deaths in each ICU that are preceded by a decision to withhold or withdraw life support. And the range is really tremendous, from 12% of deaths preceded by withholding and withdrawing life support in some ICUs up to 62% in other ICUs. And this is after adjusting for patient severity of illness, patient characteristics, and ICU characteristics. So really tremendous variability that's not explained by the patient or the ICU characteristics. There's also data from Amber Barnato and her colleagues showing that this variability is not explained by regional differences in patient preferences. A more recent study looked at variability specifically for patients who were admitted to the ICU with pre-existing limits on life-sustaining therapies. And most of these involved DNR orders, so these are patients who are admitted to the ICU with some limit, mostly DNR orders. And these investigators, if we zero in on this one graph, these investigators looked at what proportion of these patients received CPR. And you can see tremendous variability here from some ICUs down around close to 0%, other ICUs up to over 80% of these patients with a DNR order are coming in with a DNR order are actually getting CPR. And you can ask yourself, what's the right number here? I think that's a little hard to say. I have facetiously drawn the line here at 10%, arguing, maybe that's the right number. We do know that some patients will change their mind. And in fact, one study showed that up to 8% of patients admitted to the hospital with a DNR order do change their mind. So I think some CPR may be completely reasonable. But if you look at this slide, what you can see is in many of our ICUs, the number is substantially above that. And so we can ask the question, what causes all this variability if it's not due to patient severity of illness, it's not due to ICU characteristics, it's not due to patient preferences, what drives this variability? And this is one of my favorite studies from Alan Garland and Al Connors, where they looked at decisions to withdraw life support for over 1,000 patients in a single ICU. And they built a predictive model to identify the variables that predict a decision to withdraw life support. And you can think of the number there on the right side of the slide, AIC model minus AIC full, as the proportion of variability that's taken up by each of these variables. And if you look at the bottom there, the APS and GCS, that's the acute physiology score and the Glasgow Coma score, which is the best markers that they had for acute severity of illness. And that took up the most variability, as you would expect and hope. It's the sickest patients who undergo withdrawal of life support. Interestingly, even after controlling for severity of illness, age, gender, and race were predictors. Daily census and the number of admissions on that day were important predictors, as were the number of comorbidities each patient had, the diagnosis that the patient had, and whether they were admitted from acute care or from elsewhere. But even after controlling for all of these variables, which of the 9 ICU physicians, which of the 9 intensivists that worked in that ICU was on that particular day remained a powerful predictor of a decision to withdraw life support. And I think this data suggests that one of the drivers of all of this variability is differences in physician approaches to these issues. And I think this is a problem. I think that we need to develop more consensus about how we approach these issues. Not that there shouldn't be any variability at all based on the physician, but we shouldn't see it being such an important driver of this variability. So are there things that we can do to improve outcomes for patients and their families? And one of the, I think, really key studies that was done on this issue was shown here. It's a randomized controlled trial that was published in the England Journal in 2007. And these investigators identified patients that the attending physician believed would die within a few days, and they randomized 126 patients to either usual care or to the intervention. And the intervention was to conduct a proactive family meeting on the day of randomization or the following day using this value strategy. And I'll show you what that is. They also, in addition to the proactive family conference, they also provided family members with a bereavement pamphlet during the family conference. The value strategy was developed from our work looking at how family meetings are conducted, and it's a mnemonic where V stands for explicitly valuing things that the family says. The A stands for acknowledging family emotions that come up during the family conference. The L is for making sure we listen to the family. The U for asking questions that allow us to understand who the patient is as a person and what's important to them, their goals and values. And then the E for eliciting family questions. And this was the approach that the physicians were asked to take during these family conferences in the group that were randomized to the intervention. And then the outcomes that they looked at were family members' levels of symptoms of anxiety, depression, and post-traumatic stress disorder 3 months after the patient died in the ICU. And they used validated questionnaires to assess these symptoms and found 2 important things. First of all, the levels of these symptoms were very high. And secondly, this relatively simple intervention that focused on communication and providing some bereavement support for family members during a family meeting was associated with dramatic reductions in anxiety, depression, and PTSD. So there is evidence that how we approach these issues of family meetings really can make an important difference, certainly for family outcomes as well as for patient care. So let me turn now and talk a little bit about shared decision-making and how we think about shared decision-making. And I think there's growing consensus, North America, but also around the world, that in general, many of these decisions about end-of-life care ought to be shared decisions, neither entirely the clinician's decisions nor entirely the family's decisions. Often, patients aren't able to participate in these discussions because of their severity of illness. Obviously, if they can, then they need to be factored into this as well. But I think what we're realizing is that although shared decision-making is important, we should not view this as one-size-fits-all, that all these decisions should be equally shared. But in fact, how this scale comes out ought to be tilted by a number of key factors, including the prognosis, our level of certainty about the prognosis, and importantly, the family's preferences for the role they would like to play in decision-making. For prognosis and level of certainty of prognosis, the worse the prognosis is, and the more certain we are about that, the more we should be willing as clinicians to take on the burden of responsibility for decision-making if the families would like us to do that. But in these situations where the prognosis is intermediate or where our level of uncertainty is very high, then we really need to involve families much more in ensuring that patients' goals and values are incorporated into these decisions. It's also important in thinking about shared decision-making and in teaching this to others that this not be conceptualized as making everybody an equal partner around the table, that patients, if they're able, and families, if patients are not, they are the experts in the patient's values, goals, and preferences, and we need to treat them as the experts. By the same token, we are the experts in what treatments are indicated, and we need to take responsibility for that expertise. If you ask family members what roles they want to play in decision making, you get data like these. These are data from Canada, over 1,000 family members of patients in 6 different ICUs across Canada, but there's very similar data from the US, from a number of places in Europe as well as in South America. These investigators asked family members who had a critically ill loved one, do you feel like these decisions should be entirely a family decision with physician input, a shared decision, a physician decision with family input, or should this be a physician decision? And the average here, and in most of these studies around the world, the average is some form of shared decision making. But what's important on this slide is not the average, but the fact that there's a distribution, and that's true in all these studies that have been done. If we want to do this well, we need to figure out where the family is in their preferences and then match our approach to their preferences. And we have some data that we have generated, shown on this slide, that suggest that whether we're able to match our approach to the family's preferences can make an important difference. So here we looked at the family member's preferred role, now dichotomized into it being primarily a doctor's decision or the family members being involved in decision making, and looked to see whether their preferred role was associated with the development of symptoms of PTSD after a patient died in the ICU. And although there was a trend, there was no significant relationship. We also looked at their actual role. Again, same finding, a trend, but no significant relationship. But then we looked at whether we were able to match, whether there was agreement between their preferred role and their actual role, shown in green, or whether those two were discordant, shown in purple. And what you can see is that when we matched those things, when there was agreement between their preferred role and their actual role, their symptoms of PTSD were significantly lower than when those two things were discordant, suggesting that one of the ways that we can improve family outcomes is to identify family members' preferences for their role and then match that preference with the role that we actually ask them to play. That's given rise to this idea that there ought to be a spectrum that goes all the way from parentalism, where the doctor decides on one end of the spectrum, to autonomy or informed choice on the other end of the spectrum, that our default starting places for these preference-sensitive decisions ought to be shared decision-making, but that we ought to be able to move up and down this spectrum depending on the patient's prognosis and our certainty about the prognosis, and importantly, depending on the family's preferences for their role in decision-making. We did a study to look to see whether, in fact, this full spectrum is used. We had over 50 family conferences that were audio taped, and we did see examples throughout the spectrum. We saw examples which we called directive, where the clinicians provided some information but made the decision. On the other end of the spectrum, we saw examples that we called informative, where we provided information but made no recommendation and really left the decision-making to the family. And then we found two different categories in the middle that I think are instructive. One was a little bit closer to directive, we called collaborative, where the clinicians elicited the patient's values from the family and then offered a recommendation based on those values. And another that was a little bit closer to informative or autonomy, where we elicited the patient's values, placed them in context of the decision that needed to be made, but didn't offer a recommendation unless asked by the family. And again, I think the key point here is that there's not one right approach, that we ought to be able to use this full spectrum. While we did find the full spectrum was used, we found that where the conference was on this spectrum depended more on the physician leading the conference than on the patient's circumstances or the family's preferences, as opposed to what we're recommending, which is that we actually be able to move up and down the spectrum based on the patient's circumstances and the family's preferences. So one question that comes up is, that's fine, but how do you figure out what role family members want to play in decision making? And I think that this can be challenging. It's often, I find, not helpful to directly ask family members what role they want to play in decision making. At least I've found that often is misinterpreted by family members as, do you love this person enough to be involved? And it can be a hard question to ask them point blank. But I think we can listen for cues to family members' decision-making styles when they're discussing the patient's or family values, and while we're explaining the principle of surrogate decision-making to the family members, we often get some clues. We can also explore statements they make about decision-making in previous circumstances, either with this patient or with other family members. And then generate a hypothesis for what we think the family preferred role is and explore that hypothesis with the family. And I found that to be more helpful than just asking them point blank. It's also important to realize that this preference may change during a critical illness. Oftentimes, as patients spend more time in the ICU and family members get to know the ICU clinicians or the acute care clinicians caring for their family member, they may develop more trust and may be more willing to cede responsibility for decision making. But it can go in either direction and can change over time. So let me provide some tips for running and teaching good family meetings. These are tips that we've generated from our studies that looked at family conferences and audio taped these family conferences. One of the things we looked at was simply how long these family meetings were, and on average they were about 32 minutes with a standard deviation from 17 to 45 minutes. We also looked at what proportion of the time during these family meetings did the family speak and what proportion of time did clinicians speak. And we found that we spend most of the time talking. Family speech was only 29% of the family conferences, 71% was clinician speech, primarily physician, although other clinicians were in these meetings as well. We then were interested in asking whether either the duration of the meeting or the proportion of family speech was associated with family members' ratings of the quality of communication during the family meeting. And so family members were asked to fill out a survey after the family meeting, rating different aspects of the meeting on a scale from 0 to 10. For example, they were asked how well did the physician leading the conference communicate during the family conference. And what we found is that there was a significant correlation with the proportion of family speech, and that correlation was positive, meaning the higher the proportion of family speech, the higher the family's ratings of our ability to communicate. And there was no relationship with the duration of the family conference. We also asked how well did the conference meet your needs. Again, same finding. The more we let families speak, the higher they rate the conference meeting their needs. And I think this is observational data, but at least it suggests that one of the ways we can improve families' assessments of these conferences or these meetings is to actually talk less and listen more. We looked at whether there were specific things that clinicians said during the family conferences or family meetings that were associated with increased family satisfaction, and we found 3 types of statements associated with increased family satisfaction: assuring the family that the patient would not be abandoned prior to death, assuring the family that the patient would be kept comfortable and not suffer prior to death, and then providing explicit support for the family around whatever decisions were made, whether that's to withdraw life support or to continue life support. And it surprised me how often clinicians didn't do this. They really sort of said, well, if that's what you want, that's what we'll do, without ever explicitly saying, based on what we know, what you've told us about the patient, this seems like the right decision for this patient and for your family. We also looked to see whether there were specific missed opportunities, and we had an interdisciplinary team that included physicians and nurses, but also psychologists and social scientists to look at these family meetings and look for what we considered to be missed opportunities. We found quite a few of them, and they really fell into 3 categories: missing the opportunity to listen and respond, answering questions and clarifying and following up on family statements. Occasionally a question would be asked and there'd be no answer at all. More commonly though, the family would ask a question and the clinicians would provide an answer, but it'd be an answer to a different question. So the clinicians would ask, the family would ask about long-term neurologic prognosis, and the clinicians would talk about the Glasgow Coma score today and what that meant in the short term. So really missing the question that the family was asking. A second important category of missed opportunities was missing the opportunity to acknowledge and address emotions that came up during the family conference. And then the third category, what we called missing the opportunity to address basic tenets of palliative care: exploring patients' preferences when comments come up about them, explain the principle of surrogate decision-making, so the principle being that the family's role is not to tell us what they would want if they were sick, or even what they want for the patient, but rather what the patient would want if the patient were able to participate in this decision making. And at least for some family members, that can be a very important and sort of freeing explanation. Once they realize that's their role, that task may be much easier for them. And then finally, affirming non-abandonment. We also found that there were different types of empathic statements made during these family meetings, and I think explicitly laying those out can be helpful to clinicians in understanding what kinds of empathic statements they can make. We found one of the most common ones was an empathic statement about the difficulty of having a critically ill loved one. Another was the difficulty of being placed in this position of surrogate decision making. And then the third one was the difficulty of thinking about the potential of losing their critically ill loved one. And we found that the more of these empathic statements were made, the higher the family's ratings of the communication during the family meeting. So these, I think, are very important to look for opportunities to make these kinds of empathic statements. It's important, I think, in thinking about this, to have an approach to running a family meeting, and I like to think about this as the things we do before a family meeting, making sure that we have a pre-meeting with all of the team members who are going to be there. That may actually be one of the most important steps in running a good family meeting, and in my experience, one of the most common mistakes made that can lead to a disastrous family meeting is not doing this and having different clinicians in the family meeting with very different perspectives on the goals and what we're trying to accomplish. It's also important before a family meeting to make sure we're prepared going into it, that we've thought about what the prognosis is, both for survival as well as for quality of life, that we really have done our homework on the facts that led the patient to this particular situation. And then we have the right people in the room, both the right people from the family's perspective, the key people who should be involved in this meeting, as well as the right people from the clinician's perspective. I think beginning these family meetings, I like to always start with introductions. Even if people have met each other, I think it's a nice way to just be sure that everybody knows everybody in their role, either on the clinical team or in the family. I also think it can be a nice way to allow family members to use their voice early in the family conference, and that may decrease the barriers to them speaking up later. And then the next step that can be very helpful is to ask the family their understanding of what's happening. I think this can be a very nice way of gauging what the family knows and what they've heard, the type of language that they use, how much detail they go into. But I think if we are going to do this, it's really important that we be careful how we do this. I have seen a number of family conferences where the clinicians do this in a way that makes the family feel like they're being tested and sort of puts them on edge, and so it's very important not to do that. I like to put it on me to sort of say it would really help me explain better if I know what you've heard from others, as a way of sort of taking the pressure off of them. And then if they do seem uncomfortable being put in that position, to not make them flail with this, but really to step in and provide some information. A next step often is to then provide our overview or update, and I think the key thing here is to keep it simple and keep it relatively short. People can ask for questions if they want more details, but I think one of the most common mistakes made is that clinicians launch into the kind of information they give on morning rounds, where really giving too much detail and not doing it in a way that's helpful for most family members. Oftentimes after that, we then want to say, okay, that was our information to you. Now we need information from you. Tell us about this person, this patient, and tell us about what was important to them, what they valued, and what their goals were. And this is really our opportunity to have two-way exchange of information. We've given them some information. Now it's important for us to hear from them. And we really ought to think about making sure that we spend it as much, if not more time, hearing from them as they do hearing from us. It's also important to think about responding to emotions and expressing empathy when appropriate throughout the family conference. And having laid this out as a way to think about beginning and structuring family conferences, I think it's very important to realize that while these are general guidelines, it's very important to adapt our approach to the situation at hand and not feel like this has to be followed rotely. If the family is sitting on the edge of their seats waiting for some big information that we may have to give them, I think it can be really inappropriate to start by asking for their understanding, for example. I also think that sometimes it can be helpful in these family conferences to think about flipping us providing information and then them providing information to actually start with them providing information. So I think having that kind of flexibility depending on the circumstances and the goals of the conference is really important. Once we've gone through this part of information exchange, this is often where we talk about options, what the treatment options are that are indicated that might help us achieve the patient's goals. And here I think in general it's important for us to make recommendations. There are some family members who don't want our recommendations, but the majority do. And even the ones who don't, I think what most of them say is they don't want to be swayed too much by our recommendations, but I think if a recommendation is done sensitively and in a way that it understands the family's perspectives, I think it's important that we generally make recommendations. And as we think about finishing these family conferences, it's important to summarize what we've talked about, where we are and where we go from here, and this can be an important point, although we may want to do this throughout. It's an important point to ask for family questions and to allow some silence after we ask so that families have time to think about their questions. I think it's also helpful to think about tips for talking with families about withdrawal of life support if in fact that is what we are going to talk about during this family conference. I think when life support, when we are going to withdraw life support, it's very important that we not talk about withdrawing care. This is common language in ICUs, and I think it's really, language is important. I think it's really important that we not talk about withdrawing care. Our care is never withdrawn. We may withdraw life-saving treatments, but we don't withdraw care. I also think it's important not to sort of think about withdrawing aggressive care. And in fact, after withdrawal of life support, sometimes palliation needs to be quite aggressive to make sure that patients don't suffer. And it's important to emphasize that time to death after withdrawal of life support can be variable. Sometimes we can have a pretty good sense of that if patients are on a lot of inotropic pressor support. They're on mechanical ventilation with high FiO2s and high peak values. Time can be very short, but sometimes it's very hard to predict, and it's important to let families know that. I believe it's important to offer families the option of being present, but not assume that every family member wants to do that. And in fact, in one of our studies, we found that family presence at the time of death was associated with higher levels of symptoms of PTSD. And that may be simply, this is observational data, that may reflect who chooses to be there, but it sort of opened my eyes to the idea that this may not be for everybody, and that family members would rather remember their loved one the way they were before they got sick and not be present. We should support that. If they do want to be present, we should also support that. And if they're going to be present, we need to make sure that we describe that process of withdrawal of life support so they know what to expect and are not surprised by that. And here's where I think oftentimes the nurses have a much better sense of this than the physicians, and I often will ask the nurses to talk a little bit about that process. I'm going to spend a few minutes talking about the family meeting as a quality measure, because I think there is emerging consensus that having family meetings, particularly in the ICU as well as in acute care, can be a quality measure. This is data from a quality improvement project that looked at palliative care bundles in a statewide collaborative in Rhode Island across 16 different ICUs. There was a bundle that we were looking to implement on day one within the first 24 hours, including identifying a surrogate decision maker, addressing code status, identifying whether there were advanced directives, making sure that there was pain assessment, dystomy assessment, and providing a brochure. And then we had a bundle that needed to be implemented by 72 hours that included a multidisciplinary family meeting, as well as discussions of prognosis, assessment of the patient's goals, and assessment for whether the family or patient would like involvement from spiritual care. This quality improvement effort showed increased compliance with these bundles over time with a educational program and a quality improvement program at each of these hospitals. Both the day one bundles and the day three bundles increased over time. And specifically, if you look at family meetings, we went from 10% in these ICUs at the beginning of this quality improvement project up to about 40% by the end, 21 months later. So not perfect by any means, but certainly a significant increase over the time that this project was conducted. So let me finish up then by talking about the final area that I wanted to talk about, which specifically is interdisciplinary communication. And specifically, although I think there are lots of different kinds of interdisciplinary communication, I'm going to focus on physician-nurse communication and collaboration. These are data from a study that was conducted in France, in ICUs across France, asking physicians how often they involve nurses in decision-making about withdrawal of life support, and the physicians said they involve nurses about 50% of the time. They asked nurses in the same ICUs, and they actually said it was more like about 25% of the time. So really important differences in perspective in whether physicians and nurses were both involved in these decisions. And you might think, well, that's France. In the US, we do much better. Here's now a study looking at asking physicians in the ICU how often they involve nurses in decisions about withdrawal of life support. At the time of this study in the UK and France, it was the physicians, so we didn't ask the nurses in the study, but the physicians said about 80% of the time. Turkey, Japan and Brazil, they said about 40% of the time, and the U.S. was the lowest of all of the countries in this study. And I actually think, in traveling around a little bit and rounding in different ICUs, I think this data is right. And I think in the U.S. we have a more hierarchical, less collaborative relationship between doctors and nurses in the ICU than many parts of the world. And I think this is a real problem. I think that nurses are the ones who are at the bedside the most, speaking to families members the most, and if they're not involved in these decision makings, we miss enormous opportunities to support families from the interdisciplinary team. And in fact, in our family conference study, we asked the nurse right before the family conference what they talked to the family about. The vast majority had explained the equipment and the treatments. Most had actually described the family conference. Most had asked the family about the patient's values and even really talked with the family about what the family thought the patient would have wanted in these circumstances. And yet, at the time we did this study, this information was not getting to the physicians and was not making it into the family conferences in a way that was particularly useful, and I think was a real problem for us. And so we've made a number of changes to improve that, and I think we've made some pretty important improvements. I think the things that we've done that have been most successful, one is that we now make sure that nurses and respiratory therapists are a part of the presentations on morning rounds, so not just a passive participant, but actually we're a teaching hospital, so the first thing that happens when we get to a patient's bedside is the resident will tell us about overnight events. Then it goes to the nurse, and the nurse gives us all the information about the patient by systems, their labs, their physiology, what's happening with them, including the family. The respiratory therapist will talk about the ventilator and what's going on with the patient from a ventilation and oxygenation standpoint, and then it goes back to the physicians, the resident, for the assessment and plan. And this has really, I think, led to increased collaboration. It also really ensures that the full team is there for rounds, since we can't have rounds without the full team, and that they're active participants early on, which makes it easier for them to be active participants as we discuss the assessment and plan. We also are working to make sure that we have nurse participation not only in family meetings, which we've always done a good job of, but also in our pre-meetings. And that's something that we didn't used to do a good job of, and I think that if we really want the nurses to be able to participate in the family meetings, they have to be there for the pre-meeting when we talk about our agenda and what we're trying to accomplish. And so I think that really is a key step. We also more and more are trying to have interdisciplinary educational sessions, including teaching rounds, but also something we call death rounds, where we review deaths in the ICU and talk about how it went for the family and the team. And I think all too often these educational sessions are segregated. We're in silos. We're expecting doctors and nurses and therapists and others to work as a team, and yet we don't educate as a team, and I think that's a real problem. And then importantly, interdisciplinary approach to quality improvement projects is essential for success and is another opportunity for increasing interdisciplinary communication and collaboration. In terms of nurses' roles in family meetings, I think it's important to identify some of the key roles, reminding families of questions or concerns that they raised at the bedside, I think can be very helpful. Identifying opportunities for providing support for family members, whether that be emotional support or empathic statements, can be a key role. As I mentioned earlier, I think I will often turn to the nurses to talk about the process of withdrawal life support and what that might be like, particularly if family members are going to be present, because I think the nurses are often the ones who have the most experience with that. At the end of a family conference, when I talk about next steps, I think it's always important to make sure that we express the availability of nurses for answering questions after the meeting and getting a hold of the physicians if the families would like to talk to the physicians again. And then I think as part of teaching family conferences, it's important to debrief afterwards, and including the nurses in the debrief is also another key step. So in summary then, what I've tried to cover over the time that we've had together is to talk about how I believe that a good family meeting is really important for improving both patient and family outcomes. That this is a basic skill that should be taught to all ICU clinicians, and we need to be thoughtful about how we teach it. In general, shared decision-making should be our default approach, particularly for preference-sensitive decisions that are made about care in the ICU, but that we really need to adapt this to the individual patient and family and not take a one-size-fits-all approach. Family meetings are an important part of ICU quality, and I think are an emerging quality measure or quality metric for ICUs, and thinking about what proportion of their patients have family meetings. And then finally, interdisciplinary communication and collaboration across different physician teams, as well as physicians, nurses, respiratory therapists, social workers, spiritual care providers, and others is really key to high quality care in the ICU, as well as to successful family meetings. So at this point, I'd like to turn the program back over to Dr. Lown and see what questions people have.
Thanks so much, Dr. Curtis. That was really so insightful and very helpful summary of really important literature and data. You know, I was really struck by how strong the role of the physician was as a driver of variability and how much the doctor's preference influences subsequent outcomes. I was also really struck by the hierarchy slide comparing the United States with other countries and highlighting the importance of interdisciplinary, interprofessional training. And to that end, I'm going to ask the first question, which is how you actually did the training of the clinicians in the value approach, the value framework for running family meetings, and in particular, how you train for that kind of flexibility and matching of preferences.
Yeah, so I think those are good questions, and I think that we've really taken the position that running a family meeting is a basic skill for everybody, all clinicians rotating through our ICU. And so we're a teaching hospital, we have residents and fellows, and we really sort of have taken the view that we ought to approach this the way we approach other important ICU procedures. So we have a very rigid protocol, what it means to learn how to put in a central line. You have to watch a video, you have to be observed, and signed off before you can do them and teach them. And we're really trying to take a very similar approach to the family meeting as well, where we think about this as a key procedure. We think about how we teach it. We adapt our teaching to different levels, so where you want to the skills you want to make sure every intern has may be different than a resident or a fellow, and also ensuring that we teach this to the nurses as well, and so that they're prepared to provide, to be involved in family meetings and to provide really good support for families and the team.
That's really helpful. And I wonder if you, perhaps if you have any curriculum or anything you might like to share. I bet you there would be people interested in seeing if it's available. Let me ask Lynn to voice any of the questions from the audience. I have more questions. But
Thanks,
go ahead.
Beth. Indeed, they're coming in quickly. It's wonderful. Dr. Curtis, thank you so much. We have a number of questions, but before we begin, just a reminder that if you have a question and you want to submit it, you may still do so. Just type your question into the questions pane, and we'll answer as many as we can. And our first question is, are there any measurement instruments you would recommend for use in improving performance in organizations' conduct of family meetings?
Yeah, I mean, I think that the most important measurement instrument is just looking at how often these meetings are actually happening. Are they happening? Are they interdisciplinary? Do they involve more than just the physicians, but physicians, nurses, and others? And you know, we've by making this part of our 72-hour bundle, we're really sort of saying we would expect a family meeting for people who are in the ICU, patients in the ICU for more than 72 hours. We really would expect a high proportion of those would have a family meeting by the third day. I feel like that's probably one of the most important things that we can look at around this. Once they're happening, then I think you can ask the question of, how are we happy with the quality of them? There, I think we've really looked to families for their perspective on that, and we've done that both quantitatively by giving them simple survey questions, but also qualitatively by simply asking them about those family meetings. And I think those are really sort of key steps in ensuring both that they happen and that they're good quality.
Excellent, thank you. Different tact. What about difficult family discussions when both parents are not on the same page, for example?
Yeah, I think this is an issue that comes up frequently when I give this talk. Family members, if you've seen one family, you've seen one family, and every family is different. There are occasionally we run across families where there is a divide within the family and the family members don't agree. Oftentimes these divides and this disagreement have gone on for a substantial amount of time, and we're not going to change the way this family interacts in an ICU family meeting. But we have to be able to address these families and provide the best support for everyone. I think that ICU clinicians and acute care clinicians need basic skills in mediation and in working with families when there's conflict within the family. But I also think that ICU clinicians and acute care clinicians may not be expert at this, and this may be one place where we really want to bring in expertise from outside of the team, including social workers, palliative care providers, perhaps ethics consultants, others who can help us work with families to provide them with support. And psychologists as well. Many ICUs don't have psychologists available. We have a very strong rehabilitation program here, and we have rehab psychologists. And we've started leaning on them in the ICU as well and consulting them, not to see patients, but actually to see family members and to help family members through difficult times.
Good point that it's another issue that has to be dealt with and addressed and seeking help for it. That's wonderful. For telephonic nurse case managers, do you have any suggestions in approaching the family of the patient? So your family meetings have been face-to-face, I assume.
Right, they have, although we will occasionally have a family on a conference call or one family member who's at a distance who's on the phone. And I think a lot of the same principles apply to doing this over the phone as in person. You don't get to read the emotional cues as well when you're on the phone, and I think that can be very challenging. But I think I would argue that many of the same principles apply to having a meeting with a family over the telephone as doing it in person.
Yeah, very helpful. Can you say a little bit more about the role of spiritual care chaplain and their role in family meetings?
Yes, I can. I think that our research and research of others has shown that spiritual care and spiritual support for family members is one of the most important aspects to improving the family experience and family satisfaction with care in the ICU or in acute care. And it's an area where I think we really are very much behind compared to other aspects of ICU or acute care. We have a very strong spiritual care program here at the hospital that I practice in, but even so, we're only now beginning to improve communication between the physicians and spiritual care. So spiritual care will see families, will leave a great note that many physicians don't read, and we're really working on improving communication so that we can learn from the spiritual care providers what they talk to families about and what we need to know about that to help us support family members. So I think it's a really key aspect of family meetings is making sure that family members have that spiritual support if they want it. Not all do, but many do, most do. and then making sure that when that support is provided, that there's good communication between the spiritual care provider and the rest of the team.
Well, and your point about preparation for the meeting is a really good time for the group to sort of say, okay, what are the different roles we're going to play here, and get that out so that it's not confusing to the family. That's wonderful.
Exactly. Yep.
Another one, I'd be especially interested in information about this topic when children are included in the family meeting.
Oh, that's an interesting question. So, in general, I think bringing children into the ICU and to see patients is something that we support. We make sure that we have a child life specialist that works with families to figure out how best to do that and whether it's appropriate for an individual child, and then if it is appropriate, how best to do that.
Yes.
Having small children in family meetings is something that I've certainly been in situations where there's no one else to look after the toddler, and so the toddler is there in the family meeting. I will say that if it's possible to find someone else to look after a toddler, it can be distracting to the parents to both be trying to participate in the family meeting and making sure that the child is not upset or entertained. And so I think when possible, it's nice to have small children looked after by others during family meetings. I think there are older children in their teens, for example, where their participation may be completely appropriate and really may contribute both to their ability to handle this difficult situation where they may have a parent or a loved one who's critically ill or seriously ill. And they may also be able to contribute in important ways with things that they've heard their loved ones say. So I think that's slightly different from my perspective.
Fantastic. And I've got a half dozen more questions, but I think we're short on time. Beth, I'm going to ask if you have any final thoughts you'd like to share with us before we close.
Well, I think everything has been so helpful. I also am really interested in how best to teach this. And, we also teach house staff and residents, many people do. And but I'm wondering about really just teaching the clinicians, not just in the ICU, but outside of the ICU, and how to overcome resistance to experiential training, which inevitably has to involve practice, role plays, and the like. What experience do you have with that, Randy?
Well, I think you're absolutely right that this is a skill like driving a car, and you can't learn it by listening to lectures. You have to be able to practice and get feedback on that. And I agree with you. There are some barriers to that. Many people groan when they hear the word role play or the term role play. Yep. I think that those barriers are being broken down, and I think more and more physicians and nurses and others are used to having this kind of training and are getting that, in fact, that's the way you learn a skill. It's not by simply reading about it or listening to a lecture. Mm-hmm. I feel like this is increasingly becoming an important part of our clinical training.
Yeah, I agree. And you know what? Having the kind of data and evidence that you showed is really, really helpful. I think also showing clinicians, in particular physicians, their own data on family satisfaction with meetings and with communication is also very powerful if we could somehow collect and present it to them.
Fantastic.
I agree.
I'd like to thank Beth for hosting and Dr. Curtis for sharing his experience and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope that you'll join us for upcoming programs in the Compassion in Action webinar series. We have a special program on December 1st with Paul Ekman, and we'll be hosting monthly webinars in 2016. Please visit our website for more information. We know you're busy, but we very much appreciate your taking a moment to complete the electronic survey upon exiting the program. We truly value your input. Thank you all, and have a great day.